Hi, good morning, good afternoon, and good evening, depending on where you are located on the globe. My name is Richard Burchard. I'm the Deputy Director for UCSF HEALTHQUAL, and I welcome you to the second session of the 9th Multi-Country Network Meeting of the Southeast Asia HIV Stigma Reduction Quality Improvement Learning Network. We had more than 90 participants at last week's session, the largest number of participants we've ever had at our meeting. The growing interest in this meeting and in the network is an attestation to the good and important work being done in each of our participant countries. So we have a very full agenda for today's session. We begin with a guest speaker presentation on community-led monitoring by Solange Baptiste, Executive Director of ITPC, the International Treatment Preparedness Coalition. Unfortunately, Solange had a conflict with the time, but she pre-recorded her presentation, and Nadia Refi from ITPC is with us for the Q&A session. After that, we have country presentations from Thailand and Philippines, followed by a short break. After the break, we have another guest speaker, Dr. Sunisa Sutrakal from Chulalongkorn University in Thailand, who will provide an overview of a self-stigma curriculum. Following that presentation, we will have a breakout session with a brief report back discussing how to integrate activities to reduce self-stigma among PLWH as part of healthcare's service delivery. After the report back, we will wrap up the meeting and adjourn. I have a few quick announcements before we begin. As we have such a large group and introductions would take quite a bit of time, we ask that you enter your name and affiliation country in the chat box. Also, our UNAIDS colleagues, Quentin Laterre and Belize Odamna, had personal emergencies and unfortunately could not join us for today's session, and they send their regrets. Also, we would like to thank Malaysia and Vietnam for responding to the Mental Health Services questionnaire, and a gentle reminder to the other country teams to please respond to the questionnaire by early next week so we can incorporate your feedback into the section on mental health services in next week's meeting. So again, I welcome you on behalf of UCSF HealthQual, Bruce Agins, and Charlie Ferrucci and myself, and I would now like to turn it over to Bruce, who will introduce the ITPC team and the community-led monitoring presentation. Bruce.
Yeah, thanks, Richard, and welcome everybody, and really happy to see so many folks here this evening, this morning in Southeast Asia. And also like to warmly welcome the UNAIDS delegates that have joined us from the country offices, and a special thanks to Harry Prabowo, who has been working with us closely as part of the planning team. Just also to add that this is the first time we're going to use breakout groups with this network virtually. We've done them in other meetings, but bear with us when we go into the breakout groups, and you'll hear more about those instructions coming up. So without further ado, I want to introduce our next session, which, as Richard mentioned, is recorded from Solange Baptiste from ITPC. And I first heard Solange present very recently, actually, but ITPC has been doing phenomenal work for many years across the globe. And I was really blown away, as we say, when I heard the presentation by both the breadth and the depth of their work, and their combination of advocacy and research and focus on program and improving quality by underscoring the voice of the consumer and patient. And so we're really delighted that ITPC could join us, and happy that Nadia was able to be here in person for the live Q&A, since it's 3 a.m. or around that time in South Africa. So to introduce Solange, she's the Executive Director of the International Treatment Preparedness Coalition, or ITPC. and she leads community activists and allies across the globe to deliver ITPC's mission to enable people in need to access optimal and affordable HIV treatment. She has over 15 years of global program management and advocacy experience and specializes in monitoring and evaluation. She has a depth of knowledge in social epidemiology, health financing, and community system strengthening through her work on USAID and PEPFAR, health and development, and many other initiatives across Africa and Asia. She holds a Bachelor's of Science in Biology from Tuskegee University and a Master's of Science in Population and International Health from the Harvard School of Public Health. And Nadia Rafif leads ITPC's Watch What Matters strategic focus area. She has more than 18 years of expertise in global health, HIV, and human rights issues affecting key and vulnerable populations, especially those living in low and middle income countries and in the global South. She has served on the board as a member of WHO EMRO, as an expert to the Global Fund Secretariat, as a member of the Global Fund Community Rights and Gender Advisory Board, and has previously served on the NGO delegation of the Program Coordinating Board of UNAIDS representing Africa. She holds master's degrees in international relations and also in contemporary history and political science from the Université de Paris. And without further ado, we will turn the program over to the recorded presentation from Solange, and hope you'll find it as impressive as I did.
Good day, everyone. My name is Solange Batiste. I'm the Executive Director at ITPC, the International Treatment Preparedness Coalition, and thank you for inviting us today to share some of our insights and to participate in this exciting meeting. I'll be talking about citizen science. I know that's not exactly the term that we started off with. We are talking about community-led monitoring for sure. But we're couching it in the concept of citizen science, and I'll get into that later in the presentation. So we'll talk about the role of communities in measuring and mitigating against HIV-related stigma as we walk through the different kinds of community-led monitoring examples we have. So just zooming out a bit, I wanted to take a look at where we are today and where are we heading with respect to HIV, the role of citizen science, community-led monitoring, and just zoom out to what we know are the Sustainable Development Goals. And HIV is only found as like one in the laundry list under number 3, ensuring healthy lives and promoting well-being for all at all ages, right? That includes HIV prevention services, sexual reproductive health services, and drug dependence treatment and harm reduction services. So it's just one in the list. So we also know that UNAIDS has come up with its fast track targets. We used to have our 2020 targets, which were the 90-90-90, the 500,000 new infections among adults, and zero discrimination. But now we know that our targets for 2030 are at 95-95-95 for treatment, and we're looking at new infections being much less and still zero discrimination. And all of these great targets and important targets are dependent on, resources, which is money and people, very much dependent on political will, evidence-informed decision-making. I'm saying all of these points in reverse, but also reliable and whole data capture. We need to be able to see the whole picture. And, in the past, under our 2020 targets, we saw that countries were very much capable of saying that they were very close to achieving 90-90-90 because they were able to hide behind the power of large numbers. And that is no longer the case because the 95-95 targets are to be disaggregated, right, by subpopulation and key populations. And so this really requires us to have a whole data picture. Countries can no longer ignore specific populations in their countries. They can no longer ignore their denominators and pretend that certain categories of populations do not exist. and they really need to be able to disaggregate data by subpopulation. So I thought that was interesting to think about as we zoom out and get in closer to community-led monitoring as it relates to stigma. So we're looking at the value of community data, just broadly still, in the global HIV space. And I put this up, which usually makes people kind of gag because no one really wants to see rats, but it's the idea of being the researched upon. And I suspect I am preaching to the choir here, where everyone understands that communities have a central role. It's not about a program, but it's really about lived experiences of people, recipients of care. And the idea that communities can actually come up with their own ideas, design them, lead and implement and monitor and come to the full circle of what we think about in programs on their own is the concept of citizen science in itself. I just wanted to put up one other slide before I get into what citizen science is. And if I had some more time or done this a little differently, we might do a survey and kind of poll people. But mapping data source reliance. So where do we rely on for our data source in the current HIV space? So if we think of all the noise out there, we hear voices from governments, we hear researchers, we hear providers, we hear program implementers, but as well as affected communities speaking. And where do they reference their data or their sources from? And most of us, I think if we were to draw arrows to where they're going, it's most likely to the red box, which is traditional academic science. Most of us will quote a Lancet study or randomized controlled trial, some peer-reviewed journal article, but we are not really referencing citizen science in many of our discussions. So that's something to think about when we think, what is citizen science? And it's not, the term citizen science is not a new term. ITPC has its own initiative, really drawing on principles that we all use, and also, drawing on the current tide, but looking at moving from models of data extraction, so the lab rats, the researched upon, let's take what we need from you and thank you very much, goodbye, to more models of data democracy, right? So if you put all these things in a pot, if you think about that image on the side here, I'm not sure if I'm pointing in the right direction. So the image up there, life maps, community-led monitoring, which is what we all know about. We'll get into some of the definitions of that as well. Implementation science or operations research, community-led research, so other kinds of community-led interventions, and something that we have come up with called life maps, which is really just mapping the lived experiences of people to be able to triangulate and get a richer, fuller, nuanced data story. So it acknowledges that people are experts in their own lives. It pivots away from the notion that academic research and analysis are the only legitimate ways to create knowledge and data. And the name itself signals the democratization of data collection and analysis, empowering participants and respecting their expertise. So all of this makes no sense if we aren't using it for advocacy or targeted action. So we could get our randomized controlled trial, our peer-reviewed journal article, and have it published and have it printed and then not use it. Same thing if you want to come up with another term called citizen science. If you put all these wonderful things together and we don't use it for actual targeted action or advocacy to see real change in people's lives, and it's of no use. So that is critical. Community-led monitoring specifically, I'm sure everyone has a version of a definition, and I'm just sharing with you ITPC's perspective on it. It's a process where communities take the lead, right? They are the ones leading. If somebody else is leading, it's not CLM. To routinely monitor an issue that matters to them. So this is not communities responding to SIMS requirements under PEPFAR, and because they're getting money for CLM, they're going to do it. It's really an initiative that should be born out of a need. So they identify as the community their top priorities. They define indicators that they will routinely track, and this must be done routinely, right? It's not a survey. It's not a random snapshot of what's happening at a particular point in time, although that may be useful. It's about collecting data, analyzing the results, and then sharing the insights from the data with a larger group of stakeholders. So communities then work alongside policymakers and others to co-create solutions, and that is critical. We always reserve the right to name and shame and point the finger, but we also come to the table with solutions, with ideas, because what we want is for the system to work for those intended to serve, right? When problems are uncovered through CLM, they aren't resolved. The community, as I said, can escalate with evidence-based advocacy and campaigning until they achieve the implementation or corrective action by the duty bearers. So this is well, it's kind of small, I hope you can see it, but it's really starting with education. You cannot define an indicator for a standard that you do not necessarily know about. So if you knew you were supposed to get your viral load test results in this particular period of time, or you know how often you should be doing a viral load test, or in particular, what kind of services, what's the standard of care with respect to stigma, and what is actual discrimination. If you don't understand that in the context of the standard, then you may not be able to define indicators that are worth tracking. Although sometimes these things are pretty obvious, like a rude provider definitely is a red flag. But the education is a critical foundational part of where we would start. And then we move into evidence, which is the collection of data and documentation of by the community. And then there's this mutually reinforcing relationship between engagement and advocacy. So this is where the findings are discussed, the insights are harvested, and they say, okay, this is one-off, no, this is a pattern, we need to change this, what are some of the things we can put in place? So that is a sort of a snapshot of what CLM is. Really important to think about the demand side of things, right? Which is a critical part of the whole data story. And I talked about that at the start when we looked at the SDGs. If you're only getting your data source from some trial that was done and very much well-funded, resourced, and you're not hearing from the people themselves, then you're not really hearing the whole story. And the demand side is critical, the recipient of care, the users, the end users. So if you look here, sort of the triangulation point is on the left, where this person is triangulating every different kind of map. Also, if you think about COVID times where you're supposed to have social distancing, you see social distancing supposed to be happening, but you have a guard and people lined up, crammed on each other, and then those that are socially distanced. So what actually happens in different places really will give you the whole picture. And then sometimes communities ask or care about things that are just not tracked. They don't, the systems or the programs, the donors don't necessarily care to track that because that's not a measure of success for them. And so if you want the whole picture, community data is really a critical and a valuable piece of the whole data story in the global HIV response. And I think everyone here would agree with that. These are some of the CLM definitions. I thought it would be good to put it on one page. From UNAIDS to PEPFAR to the Global Fund, French 5%, you'll see it's really about a culture of accountability, right? So CLM is not about throwing up some widgets and saying, here are best examples, as someone explained to me, but it's really about a culture of accountability and building that in where CLM contributes, and there are other tools in the arsenal that we can use to create that culture. So accountability mechanism, led and implemented, initiated and implemented, the focus of both quantitative and qualitative data about services. The Global Fund then talks about ongoing basis, so it means it's continuous, right, to improve access quality and the impact of services to hold providers and decision makers to account. And then the French 5% talk about citizen involvement, complementary alternative to institutional and information systems. So that really gets to the point that I was making, that you need to get the whole data picture. Okay, so the DSD policy development and the lack of an indicator are two examples I'd like to cite under the impact and the advocacy win in Sierra Leone using community-led monitoring. We'll get to stigma. I just wanted to raise the fact that the policy development where there were no indicators, KP-specific indicators with NETHIPS, which is the national network in Sierra Leone, they turned KP-specific data into what is now the DSD policy in Sierra Leone, and the policy was signed by the government. This was initiated by the National Network of People Living with HIV when they were trying to track data on KP-specific indicators, and that was not disaggregated. And so the idea of knowing about the need for differentiated service policy and then working with the data that they found, which showed a gap. And the same thing here, because often we would have conversations with community-based organizations to engage in CLM, and they would say, well, there's no indicator on that. The fact that there isn't an indicator is something that we should also bear in mind. So in this case, NETHIPS also discovered that the current service register did not capture that particular indicator around treatment failure during COVID. And if you read through the whole slide, you will understand that NETHIPS then secured a commitment from the national agency, the National AIDS Control Program, to develop a tool, a new set of service registered, and to capture this indicator. And I love the quote from Martin. He says, the beauty of these projects is that they identify how people fall through the cracks. We'll be bringing this issue to the community consultative group, which is sort of analogous to the CCM in the ITPC model, but it's just a place where they discuss things, and advocating to the NACP to accelerate the production of new treatment registers that include treatment failure as an indicator in them. So some of the key gaps and challenges within CLM I wanted to flag is that because CLM is like the sexy thing now and everybody's trying to do it or doing it, not everybody knows exactly what it is. So some are encountering it for the first time, CCMs, communities, governments, a mix of understanding, and this therefore leading to a longer than anticipated time for orientation and implementation of CLM itself. So, there's money, there's a deadline, it must be done, where are your targets, where are your results, and that is a very tight timeline if you're really encountering CLM for the first time. So that's what we're seeing in the landscape. Communities are unclear of how to balance the need to accommodate donor indicators while determining relevant community-defined ones, and that is very particularly important for things like stigma. And data is not always used optimally. Data ownership and security under CLM is not well understood. So who owns the database? Where does it sit? Who has access to it? What are the ethics involved in the data collection as well as the data use, management, etc.? And then there's a need for tighter coordination between the global CLM initiatives and what's happening at the national level with communities. So I wanted to put up these two indicators. Again, I'm sorry I'm not there in person, like live, but what does 19 hours and 45 kilometers mean to you? What do you think these measurements represent? So I'm going to pretend that you're coming up with ideas in your mind, but this really represents how long people are willing to wait to see a kind provider versus a rude one, and how far they're willing to travel to see someone that will give them good service versus someone that was going to give them poor service. So this really indicates to the point I was trying to make here, which is, what do recipients of care about the most when seeking healthcare, right? What do you care about the most when seeking healthcare? And it really is about quality, as indicated also by that slide. And this Lancet study that is on this next slide in 2018 found that there were, of the about 800,000 deaths in Western Sub-Saharan Africa that were related to health, about 43% were due to the poor qualities of services. So what this is saying is that improving access is not as important as high quality. And herein lies the important discussion around stigma. So it almost doesn't matter if you stay at home or you go to the clinic, your outcome might be the same, because this is almost 50-50. You're looking here at deaths due to the use of poor quality services and the deaths due to not using health services at all. So that is a really sad day to know that that's what's happening. So this really is a good segue now into examples of community-generated stigma data. I'm going to just touch on a wide swath of things across the globe, looking within the context of community-led interventions, but with a focus on community-led monitoring. So the first example is really around the regional community treatment observatories. This was a 3-year Global Fund regional project in West Africa. So this was led by 11 PLHIV networks in West Africa. So 11 countries, and you're looking at the sort of the power of the data here. So about 15,000 young people, key populations, both qualitative and quantitative data, and about 101 health facilities. So here we're talking about the regional community treatment observatories, right? That was the data that I'm referencing. So here's the example under CLM. We're seeing here that you are able to find actionable data through CLM specific to stigma. So in the focus group discussions with young people, we see that confidentiality and privacy was emerging as a top reason for not accessing ART. In the 19 focus group discussions held with MSM, sex workers, people who inject drugs, fear of stigma and discrimination emerged as a key reason, right? So in terms of the advocacy efforts that were engaged at the regional level, looking at now working with ECOWAS to hold countries accountable for collecting data on key populations, because sometimes they just they seem to not exist, and investing in stigma reduction programs. So this kind of data can then allow us to hold these duty bearers accountable at a national, at a very local, provincial, national, and even regional level. The other example is around empowering communities to end TB. This is the work done with One Impact and ITPC, combining qualitative and quantitative data. And this is really talking about getting to the nuance and the richness that happens when you get deep into the qualitative discussions, right? So that the quantitatives can sometimes trigger questions that need to be unpacked. And you want to understand, as in the second bullet, the numbers don't, although powerful, do not tell the whole story. And so what, as well as the why is that happening? And we found that 70% of the One Impact users reporting experiencing stigma and discrimination confirm that the most common reason for TB stigma is a lack of information among family members, which is interesting because then that will actually change how and where your program intervenes. I think these things are quite interesting. The other example I'm referring to here is under the Global Treatment Access Survey undertaken by ITPC across 7 regions and 14 countries. And we see that stigma is still a pervasive and deadly barrier to HIV services. 2/3 of all the respondents experienced an episode of anticipated stigma. In the previous 12 months, they avoided social gatherings because of their status. They had not disclosed their status to, to any family member. And more than 1/3 experienced an act of stigma, right, in the previous year. Gossip, harassment, loss of jobs, and physical assaults, which is really unfortunate and sad. Stigma remains pervasive, especially for key populations, right? So almost 2 times worse. Members of key populations are especially vulnerable. MSM and sex workers reported denial of health services significantly more than the general population, and internalized stigma among about 60% of respondents. So self-blame for the HIV status, decision not to have sex, and decisions not to have children. So these are just some quotes about what recipients of care have to say, and I have maybe about 4 more slides. So hopefully I think I'm within time still. What do recipients of care have to say? And I'm sure that everyone here, I'm not surprised by these quotes. They should offer KP-friendly services and not threaten to report us to the police. This is an MSM respondent in Uganda. The other one is a man living with HIV in Ukraine. He says, I don't want to tell people at work that I need to go to the hospital or AIDS center because I could be fired. I'm afraid that my bosses will think that I'm too sick to perform my job. A transgender person in Zimbabwe, 32 years, healthcare workers used to ask me some funny questions like, are you a boy or a girl? And they call each other to come over and see me, and they start laughing. A man living with HIV in Burkina Faso, I hide my pills at work in a locked cabinet for which only I have the key. I always wait for my wife to leave the room. She's seen me before and asked what I'm taking, and I said I had food poisoning. I've experienced discrimination during pregnancy where I could not access PMTCT services because I could not produce a husband. I'm a sex worker and I had to go to a neighboring country in order to access services. So things are quite dire and we really need to figure out better ways to address stigma. And so these are some examples here also of more recent work. In April 2021, which is this year, work in China, Guatemala, India, Nepal, and Sierra Leone. We're looking at community pandemic preparedness and specifically community-led monitoring effects of community-led monitoring of COVID-19, effects on service delivery and lived experiences of people living with HIV and TB in those countries. And if you see the quote, it says, "I worry that healthcare workers and doctors will disclose my HIV status to others. Social distancing is scary and makes me feel alone. Because I'm HIV positive, I'll get worse care from the clinic. I know the nurses and doctors are anxious and scared about COVID. I know that they will think that people with HIV are dangerous, a more serious risk of transmission." So very interesting ways that people are thinking and what their lived experiences look like. Some other excerpts from there: HIV stigma was compounded with stigma related to COVID-19 as well as TB, loss of confidentiality about the HIV status during the pandemic due to new requirements such as disclosure of HIV status to policemen and other state officials before accessing health facilities. This is an example in Nepal. In China, this person was talking about employment and discrimination that happens with medical treatment, with this new law that requires HIV testing for both employment and schooling. And this one here is looking at further excerpts in China. We talked about the issues with medical discrimination. So this person is explaining that they have had, but I have heard that because I'm infected with HIV, I need to go to a designated specialist hospital for treatment. When I go to a general hospital, the doctor may use other excuses not to perform surgery. And this kind of discrimination also exists in employment. Professionals like civil servants, teachers, medical examination standard needs to be screened for HIV. So many people have passed their exams, but because of this reason, they may lose their jobs. 26-year-old transgender person in China, talking about really having to resort to different ways to hide their HIV status when seeking medical care. And I thought this quote was interesting here about COVID and TB in terms of their symptoms. Since COVID-19 and TB have the same symptoms, people get confused. So when I cough, people think I have COVID and no one wants to sit near me or talk to me. And this is someone in India trying to access services. This here is referring to a community brief that was recently done again in April, integrating community-led monitoring into the Global Fund C19 response mechanism funding requests. So this was looking at monitoring of service access and satisfaction among KPs in Malawi. So looking at female sex workers, the NGO is implementing an observatory client satisfaction survey using a CLM model where the data information is in a feedback loop and is done routinely. They share information in real time to inform this evidence-based advocacy for better services. So what they noticed was a drop in the numbers of clients recently, and they were therefore conducted sort of an investigation. They said, this doesn't seem right, what is happening? And they noticed that there was an issue with some of the staff members that had negative attitudes towards female sex workers, and therefore was delivering poor service. And so they were able to use this information to conduct service provider capacity building and training and orientation, specifically on KP service provision, which resolved the issue of stigma and negative attitudes towards female sex workers in that particular instance. But it really speaks to the idea of catching issues more at the real time and having this local data for local change, quick feedback loop. So if you're able to catch things, they don't then, become this bigger issue that needs really different, higher resource and more resource intensive interventions. So zooming back out again, this is my last slide. I think I'm around 28 minutes, I'm not sure. How will we know what we need to change or where and how to intervene on stigma before 2030? Because that's where we're going in terms of our targets and as a global community working on HIV. And I just wanted to, put forward that it is impossible to do this without both sides of the coin, the supply side, the provider side, as well as the demand side, which is the user and the recipient of care. Traditional M&E systems are set up in a way that they do not integrate community data as part of the data story in a way that is appropriate, and they don't do it in a way that is adequate. They don't allow the space for the designing and targeting of interventions, particularly around stigma. And so I want to put forward that community-led monitoring is a critical tool in our arsenal, and I think everyone here would agree with that, especially when applied to stigma. So thank you very much for your attention. I hope that this has worked in terms of my new technology trial. Thank you very much. Look forward to your questions. I think Sam and Nadia will be there to answer them. Thank you.
Thank you, Solange, wherever you are. And I'd like to turn it over to Nadia Rafif now, who will share a few more slides to continue the presentation.
Yeah, thank you. Thank you to stay with us. So Solange really apologized, but she's with us in spirit. So can you see my slide? Yes. I guess so.
Yes.
Okay, so I just joined ITPC 6 months ago, but I know ITPC more since their inception, and I always have been very admirative about the work they have been doing with community. And here I just wanted to add 3 slides, and I want, of course, to give time to open the floor for question and answer. So here, I just wanted to highlight, some of the key results that we have seen and the impact of community-led monitoring, especially in West Africa. Oh, sorry, I have a problem. I'm sorry, my slide doesn't want to move in and out, so I will have to do like that. I apologize. Huh? So quality of care, and what is the relation between quality of care and community-led monitoring? Yeah? We heard Solange, but I just want to remind everyone that community-led monitoring has a broader mandate, and it includes community system strengthening, health education, literacy, and targeted action and advocacy, and continuous monitoring over time. So that's what we did in West Africa. And the community treatment observatory that were in place during 3 years were collecting and analyzing data on availability, accessibility, acceptability, affordability, and appropriateness of HIV care and services. And you will have the slide, so I'm going pretty quickly. And as Solange said, right, it was happening in 11 countries in West Africa. And you can see here the power of big data, right, in the hand of the community. So what is here? That's where I wanted to go, right? So what kind of data can be generated from CLM? And I think it's pretty impressive, and it has led to quite impressive change also at country level. So here you can see on the top row, right, the decrease over time, and it's about 1.5 years, right? For example, the figure 1 shows the frequency of recorded IRT stockout in a West Africa monitored facility, and you can see, right, how the number of stockout have decreased during this period of time. The same for the viral load lab supply stockout. So a quite impressive also decrease over the period of time. And the length day of IRT stockout also decreased quite substantially. And it really can be attributed also to the community-led monitoring, which happened during this period and which led to some advocacy and improvement. I will show you later. So, and on the contrary, the average quality of care rating at the monitor health facility increased quite also impressively, as well as the viral load test performed and the rate of viral load suppression as well. So what do we want to say here, right? Like, we mostly want to insist that monitoring and gathering data is has to come up with advocacy action, right? So here, again, a snapshot of the advocacy priority that was set up by the West Africa country engaged in the monitoring exercise with ITPC during 3 years. So they identify multiple routes for advocacy, right? Expand the availability of non-facility-based HIV testing option, include objectives to promote and protect human rights of people living with HIV and key population in costed HIV strategic plan. As for the access to RLT, they improve communication on the supply chain to prevent stockout, enhance leakage to and retention in care and treatment, especially for key population, strengthen community system. And finally, on the viral load issue, increase funding to ensure the availability of adequate viral load testing machine, enhance knowledge among people living with HIV and healthcare workers to increase the demand, and ensure effective treatment monitoring. So all of those advocacy issues came up from their monitoring exercise, right? And so even more importantly, so again, sorry, of course, technical problem always arrive at the last minute. So we have example of advocacy within every country, and Solange gave some of it, but here, for example, you can see in Sierra Leone that also the DSD issue, right, that Solange talked about, sorry, she already talked about this, but it was a big achievement because a change of policy. And you have many examples. We have many other examples in every country. And finally, and it's my last slide, here you can see from 4 countries, right, some of the testimony of the people who are involved in this monitoring exercise. So through this project, network of people living with HIV were able to mobilize additional funds from other partners. So community-led monitoring also is a sustainable, right, ensures sustainability. The project generated high-level political will and buy-in for community-led monitoring. So in several countries, finally, people living with HIV network and other key population were taken seriously, right? Because they were coming up with data, with a strict methodology, so data that are credible. And their watchdog role was formalized into national policy document, framework, and agreement. And this advocacy also contributes to the development of differentiated service delivery policy in multiple countries. And also as importantly, over the course of the project, the number of new RT initiation among key population increased more than 17 times at the monitored seats. So that's my last slide. What I maybe want us to remember is that for the community-led monitoring to be successful, there is some contributing factor, right? We need a strong leadership from the community in charge of this. The model must be embedded into the national response, right? It's a co-creating solution. It's not duplicating the M&E system, but it's working together and trying to change what is not working. It's moving from an ad hoc alert system to systematic monitoring. Again, countries need to understand that it should be routine. It's different observatory function at different level, of course, and data-driven advocacy works. So that's our last slide. If you want to know more, we have many resources that are available in our website, but I will end here to allow questions. And thank you very much, everyone.
Very good. Thank you, Nadia. Thank you very much. If you have questions, you can put them in the chat or raise your hand. We have a couple of questions from the chat already. Dalen, thanks you for the comprehensive presentation, and has a question about how the community tracks the change made from the use of CLM data for advocacy. Is there a standard tool to track the change and ensure consistency of tracking across the state?
Yes, so I'm sorry, I had no time to look at the chat, so I count on you to
Yes,
to
will.
tell me to tell some question. So do you want I answer right away for this one? Yes, so of course there are some standardized tool, but every context is different. We used to have some tool have been developed, right, by UNAIDS or by a TPC, and that could help inform what you want to do at country level. But before starting a community-led monitoring exercise, usually what we do is a workshop gathering, you know, community and other stakeholders involved to first identify the problem and to define the framework and the indicator together to really tackle what is happening and to adapt it to the context. So there are tools, there are guidance, and again, we can share those documents, but they should be adapted after to every, even at the district level. So I see your hands, but I cannot see you.
I'm
Richard,
sorry.
you were on mute.
I
Yeah.
was on mute, I'm sorry.
Yes.
There was another question from the chat from Hyo. I am interested in knowing more in detail about the formalization of CLM and national policies.
I'm sorry, the what?
Formalization,
Of
formalizing
CLM in national
national
policy.
policies.
Yes, so the chance we have with community-led monitoring is it's really fully recognized by, and it was before, right, by PEPFAR, Global Fund and others, but even more now, right? It's UNAIDS as a full technical assistance program only to support country on community-led monitoring. Global Fund has a set of funding available to include community-led monitoring within national funding request. And PEPFAR, we know since 2 years, has also included CLM almost as a mandatory, right, provision for PEPFAR funded program. Not mandatory, I don't want to say that, but like strongly encourage community monitoring. So it's becoming much more easy to convince our own CCM or national authority, right, to include CLM first because funding are available, and also because there is proof of concept, right? So I guess there is still advocacy to do in some country because government are afraid that CLM will be just a way to show, to say, hey, look at this problem, right? You're not doing your job, but we need to be very strategic in convincing them that it's a co-solution exercise to address problem together.
Thank you. And back to the tracking tool, would you be able to share that tool with us that we can share with the rest of the network?
No, totally. We are about to finalize the CLM toolkit together with UNAIDS, and we are in the final stage, which means it should be available in 2 weeks. So, of course, we could share that with all your network and people who attended your conference.
Good. Appreciate that. Thank you. Any other questions? Just
Richard, Harry has a hand up. Yeah.
Okay. Thank you, Nadia. Thank you, Solange, for that. Then I think it's curious because, you know, as I mentioned in the CLM, you know, when we're talking about data pictures collected by community, but many government is not, you know, sometimes they are not trusting the data that collected by the community, or not be able to get a buy-in from the government or stakeholders in the countries. And I'm just wondering, especially we're talking about the narrative that we can try to show it to the government. This is the problem, you know. But then I just wondering, you know, as you also mentioned, also the way to do it is to conduct it through advocacy. So from your base experience in the West Africa, in those countries, are there any taking point that you can share with us in how to ensuring that our data, the community data on the CRM can be to get the buy-in from the government or stakeholders or policymakers in order for them to, you know, to make a change for better? Thanks.
No, it's a very good question. And as you say, it's still not easy in most part of the world. And we're working also in other setting outside Africa. And I think what really helped is the partnership with academic institutions. So here we have not the detail, right, all the steps to implement a proper community-led monitoring in a given country. But one of the steps is, especially when we are defining indicator and creating a database, it is to enter in partnership with either a university at country level or a research group or an academic institution, right? Which will first give you guidance, right? And oversight, and also to have this credibility, which is, it's a pity, right? We still need to be, to convince other, but then it gives you more insight, you know, like solid, like way to show to our ministries, right? That we are working on serious data. So that's in many countries, they are doing this partnership. And by the way, community-led monitoring also in many settings means we need to get authorization, right? Like from health facility, but also often IRB approval, right? Which mean like a research, which mean that's becoming even more critical to partner with an academic institution, which could help, right, to have this proper authorization to lead the CLM. So it has helped a lot. Of course, there is different tactique. The fact that Global Fund and PEPFAR also have funding, right, could help, especially when we sit on the CCM, to convince ministry about the interest of conducting CLM. And we also try to do some case study, right, exactly for the same reason. Maybe showing what others are doing could be helpful also. Thank you.
Thank you. And Chad, thank you for the comment about CLM and quality improvement activities that you put in the chat. Good. Other questions? Yeah. Okay. Well, thank you very much, Nadia, for thank you very much. I think that concludes the Q&A, and I would like to turn it over to Harry now for the beginning of the country presentations. Harry.
Thank you, Richard. So, hi everyone. Good morning, good afternoon, and good evening once again. I'm Harry Prabowo, Program Coordinator from the Asia Pacific Network of People Living with HIV based in Bangkok, Thailand, or many of you known as APN+. And for the next hours, I'll be sharing a session, which is the country presentation. As we heard from the day one, during the day one, there were two country presentations from Cambodia and Vietnam, where this country has presented challenges and innovation thus far. So for the next session, we will hear another country presentation from their quality improvement and to reduce stigma and discrimination on the respect country. So without further ado, I would like to introduce the first round of presenters, which is coming from Thailand. Two presenters will present their presenting, which is the first one is Dr. Darinda Rosa, MD, is his Chief Development of HIV/AIDS Treatment and Care Cluster Division of AIDS and STI from the Department of Disease Control, Ministry of Public Health, and then followed by Dr. Krinkrai Sritina Vibonchai, MD, MPH, Associate Professor at the Research Institute for Health Science and Faculty of Medicine in Chiang Mai University. So, Doctor, the Zoom platform is yours.
To extend to application period to 5 hospitals interested in the program might be delayed due to the hospital having no time. Next is data collection, national surveillance survey every 2 years. And the last, we apply two-way to work, for example, meeting room, training, e-learning, virtual meeting, and extra. And that the implication of COVID-19 in Thailand. Here now is the researcher Institute for Health Science and Faculty of Medicine from Chiang Mai University, Dr. Kiang Krai Si Thanaviboonchai, to talk about HIV-related S&D among key population in Thai healthcare facilities. เชิญค่ะอาจารย์ Dr. เกียงไกร
Hi, good morning and good evening to everyone. Could you please advance the slide to the next slide for me, please? Okay, so I'm going to the previous one, please. Okay, now I would like to give an update on the additional analysis of our data that collected from the 48 participating hospitals in the S&D reduction in CQI project. Next, please. Next, please. In previous meeting, we already presented the result of the 3-round surveys that including baseline surveys that we collected information before the intervention, and also the post-intervention survey that we collected 3 to 6 months post-intervention, and long-term survey that 1 year after the intervention among the 48 participating hospitals, and include separately 2 surveys. One is from the health staff and another one from the PRHAV perspective. And in this presentation, we are going to report the result of 2 additional analysis using the same data set. The first one is the subgroup analysis among the PLHIV participants who, previous one please, who were the key populations. And we capture the HKP status of the PLHIV participants by asking them with the questions about the KP status. And we put this question as the last question due to its sensitive nature. And this is the proportion is naturally got from the survey. So we didn't have any additional attempt to oversampling the key population. Another analysis is the discrimination attitudes toward key population within the last 12 months, which was observed by the healthcare worker participants. For this question, we asked all the healthcare workers, but to have a proper denominator, we exclude the staff who reported that they didn't aware of KP clients in the denominators. Next one, please. This just to show how many key populations in the surveys. The first column is baseline. The next one is post-intervention, and the far right is long-term. As you can see that for drug users and migrant workers, the numbers that we got were quite low. So we did the subgroup analysis among these 2 groups. We did only among the MSM, GG, and sex workers. Next one, please. First, I'm going to report about the data that we got from the PRHAV that were key populations. Next, please. Okay. First is from MSM participants, and the first one is about experience and unauthorized disclosure of HIV status during the last 12 months. The blue bar represents the baseline information. The orange one is post-intervention, and the gray one is the long-term. There were 2 questions in these categories. The first question we asked whether they thought healthcare provider ever disclosed their HIV status to other people without your consent. And as you said, there was a decreasing trend from post-intervention compared to baseline intervention and continue to decrease for the long term. As well in the second question, your record was marked as being HIV positive in a way that let people around you know you are living with HIV, also decreasing. Next, please. This is another dimension. It's about experience discrimination while receiving care during the last 12 months. Also among MSA. For the healthcare provider refuse to attend to you or you deny treatment, the post-intervention increased from baseline a little bit, but decreased for the long term. But for ever being told to come back later, put last in queue or made to wait longer and receive less care or attention than other patients, the trends continue to decrease throughout the 3 rounds of surveys. Next, please. So move to transgender women. You can see the similar trend with the MSM for the experience unauthorized disclosure of HIV status. Next, please. And for experience discrimination, for the later to patients ever been told to come back later and receive less care and attention also show trend of decreasing, but only the first patient that it's decreased and then increased for the long term. Next, please. So the last group of the key population that we did the subgroup analysis is sex worker. You can see for the experience of unauthorized disclosure also the same trend, so decreasing. Next, please. The same as the experience discrimination also in the sex worker. Next, please. For health staff survey, we asked all of them, and I have only one slide. Next, please. We asked them separately if they observe any discriminations toward a specific group of key populations. So 5 of them: migrant workers, drug users, sex workers, transgender women, and men who have sex with men. So all but transgender women, we see continuous trend of decreasing of observed when compared post-intervention with baseline intervention and the long-term intervention. Next, please. Okay. I think for subgroup analysis that we conduct additionally among people living with HIV who were key population, it reveals similar results with the overall analysis that we previously report in the previous meeting, network meeting. In the overall analysis, we also saw the same decreasing trend. And the stigma level was lower in post-term intervention compared to baseline survey, and continue to decrease in long-term survey on most indicators and in all key population groups. Analysis on observed discrimination towards key population by healthcare workers show similar trends of improvement, except for transgender women, in which the post-intervention observed discrimination was higher than baseline, but decreased for the long term. Small sample size might explain the inconsistency of the result. Next, please. And I think in conclusion, we can conclude that the intervention, which include the S&D reduction training, and also the CQI program, also benefit for the key populations in the participating Thai hospitals. Thank you. That's it from my presentation. Hand over to Dr. Darinda, please.
Come back again. Let's talk implementation and intervention. In 2020, we implemented the 3x4 package in 9 hospitals and also continue in this year. The main objective is to provide an example of S&D, CQI, and conduct guidelines in healthcare facilities. In this year, we have only 5 places to do S&D QI in the COVID-19 situation. We found a difficult challenge in only 3 months of working, such as the 3x4 approach planning, data collection, the difficulty of meeting or training. For example, Paisali Hospital has 3 main things to implement that include the system for PL-HIV service, the health provider and survey training, and lastly is PL-HIV survey. Since PL-HIV can go to the hospital to receive medicine in hospital, healthcare worker, they have a solution by sending QR code to do questionnaire and send medicine by post or contact with them via mail. Next, we have national management strategy and policy. We set 2 goals, include S&D, QI, routine work, and mobilize the coverage 3x4 package in healthcare facility. And next, about background. Thailand's background of HIV/AIDS situation. We have natural scale up of S&D reduction in healthcare settings since 1717. We also pilot 3x4 approach in 3 provinces, 6 hospitals. And in the following year, we integrated with CQI and start to work self-stigma reduction program until 2021. We have 71 provinces and 116 hospitals to join with us, as seen on the slide. Moreover, we have several programs implemented that can separate into 3 levels, includes new, basic, and advanced. We put in different intervention in one setting. In each level have a 3x4 package and e-learning based of process. The advanced level is a completed state with the include a 3x4 package, self-stigma reduction program, crisis response system, and S&D e-learning, and also plus tuberculosis. In 2021, we have 71 provinces and 116 hospitals join us. Next up, we talk about QI coaching. In the critical situation, we apply work routine to the online participant. We follow the QI and give coaching by virtual meeting and inform the information via application line. In additional, it's also a way to contact us immediately. What consumer feedback and involvement? For example, the counseling service in Songkhla Hospital, they have evaluated about the providing service to clients, which included many questions such as the period of time, waiting to get consult. The counselor will try to understand the problem and give the solution of them. Moreover, the part about evaluation is to check their last experience we got this counselor consult to create room for improvement. This slide was clearly client satisfaction with counseling and STI clinic, which was reported in October 2020. A number of clients who responded were 30%, and the summary satisfaction of counseling service is about 98.6%. Clients get to benefit from counseling and be satisfied with service received by 100%. And that's how successful the counseling field is. Next one, we talk about community-led monitoring. In the field of work, Thailand had a crisis response system and self-stigma reduction program to link it with the community. By crisis response system, we provide training to extend the operation and follow-up. Furthermore, we discussed with HIV/AIDS core group and the community representative. Part of PL-HIV index. People living with HIV stigma index integrated with S&D QI in a new area to collect the data. SD national survey and community assessment in general population every 5 years from 2015 till the present. Lastly, the innovation and challenges. We set S&D e-learning in healthcare worker crisis response system, self-stigma reduction program, and 3x4 package with QI worker called the S&D Innovation Storage Box. The ongoing innovation in 2021 include the S&D QI in virtual learning center, crisis response system on mobile phone, and updating self-stigma reduction program manual. And next, a web-based crisis response system. What is and how does crisis response system work? We implement this system in 14 provinces in Thailand. We cooperated with several organizations such as Foundation of AIDS Rights and Thai Foundation or Thai Network of PL-HIV. The main objective is to protect people's rights. And the method include event report, screening, investigation, resolution, and reporting. Self-stigma reduction program or SRP. Thailand started this program since 2016 till 2021. In this year, we extend the SRP into hospitals, which are Kukan and Nong Rua Hospital. We have a handbook about self-stigma to reduce stigmatization in healthcare setting and virtual meeting title. Develop the potential self-stigma reduction program in a new normal in COVID-19 pandemic. Moreover, in the next year, we need to extend self-stigma reduction program at least one hospital in each year in 13 regions. The challenges. In the situation, we found big challenges to extend 3x4 package to nationwide coverage quality in integrating with work routine, link it with the community and create public awareness by new strategy boosting the performance. The last but not least, we developed an S&D e-learning for medical and nurse students to extend the 3x4 package coverage nationwide, refreshing the S&D CQI activity in 116 hospitals, integrated with the S&D tuberculosis and routine of quality work. Thank you for your attention. If you have any question, feel free to ask.
Thank you, Dr. So there was one question from Bruce, basically, was asking about this, can you also break down the key population, KP healthcare workers database on geographical and the type of health facility? And also another one is coming from Dr. Angelo John Ramos, which is the SRP initiative is very interesting. This publication method can be shared with everybody.
May I respond to the Dr. Bruce question first? I haven't done that yet, but we'll do, yeah, and we'll come back to report to the team. It would be interesting. Thank you.
Okay. Okay. So, while we're waiting for some people to raise their hands or they want to share their question in the chat room, I have a question. Basically, I just curious about the crisis response center that Thailand has been carry out. Is there, how you go? I'm just wondering in what sort of avenue that the crisis response center is being socializing? Is there, or how is the progress so far? Like say, is there any clear data where the community can share the complaints related to stigma, discrimination, and so forth? And and then what's the mechanism on how to address the complaints from the community? Thanks, Dr. Dr. Dorinda probably can answer that.
Excuse me, please again your questions.
Okay, so I just wondering about the response center, the crisis response center. I just wondering, do you does this response center do the marketing strategy for demand creation to to enhance the community to use the community crisis response center, and if it does, then what sort of like a platform or avenue that you use, and then also the mechanism on addressing the data from the complaint from the crisis response center.
For CRIS, CRIS, if you remember the slide, Thailand has also partnership that from CDC and Foundation of AIDS Rights and other NGO and other HIV reader to establish for the CIS. Now the CIS, the central CIS system is on at the handle of the Division of AIDS, CDC Thailand. But in the future, we plan to organize for some organized to handle, such as for the social and labor ministry. Everyone can join and can attend to this CIS system, because nowadays we adapt for the easy for fairly easy on the mobile phone, but now is ongoing. The objective, the big objective for the clients can use and can use this by yourself for campaign. But now we share and train with the pilot province, and the leader and the PLHAV leader can use for this and can see their campaign and manage this problem, such as we have some great example from the Songkhla province. And for the next chance, we can join and talk about with this for CIS. Thank you.
Okay, thank you. I think I just in the chat there is a follow-up question from Mazri Zarami, MOH Malaysia. Basically, she was asking about the is the crisis response center only for complaints related HIV-related stigma, discrimination at the healthcare facilities, or people can complain about anything in regard to service to the facilities? Can you explain about that a little bit?
Yeah. Dr. Darinda, crisis response system is a program like you can search from the Google and write the สวัสดีปกป้องค่ะ can this program will bring to the process in the about the implementation about we have the event report like we check first is the violent or not is the true for the complaint or not, and after that we go back to the screening. We have staff, they are multidisciplinary in the we get the multidisciplinary for the check like a staff to assessment this about complaint, and also we have the lawyer in committee. We have a lawyer in committee and finish in this committee, and also after that we go to the investigation, staff investigation, and after that the solution by the legal support and education support and counseling and justice support. After that we report in this program. Just finish all.
Okay, so basically,
May I add something a little bit? I'm Dr.
Okay.
Trenkrai. Okay. I think that the CIS is a very wonderful system. It's an online system that people can raise complaint to the system. And to answer the question, it focuses on the HIV/AIDS related service. But not only that, people can report about the sexual health related and also the human rights violations also. So it's not just HIV. And as the team reported that they try to engage all the related stakeholders in the country so they know about this and promote people to use this system. And I'm not sure if the team in Bangkok, you are on the internet right now. I think it's a good time to show our short video clip, the Pokpong clip on the YouTube channel. That the short video one that would be wonderful. I think it's a very good one that will explain the system to the meeting. But if it's not possible, maybe next time. Thank you.
I will show the clip video for สวัสดีปกป้อง
okay.
If we have HIV, what should we do? If we are tested and we found with drugs, I'm so worried. Hello, สวัสดี how are you? This is ปกป้อง may I help you? How can you help? Please come. Check this app. So, how are you? Do you want ปกป้อง to help you? ปกป้อง is a helper, online helper. We accept the information. We would like to get information from you. We would like to help the vulnerable group. ปกป้อง is on the CRS system, crisis response system. We protect people who were discriminated. We have a team to help you in many aspects. If you were asked to test for HIV inappropriately, when you don't really want to test, if your result of HIV were distributed to others, or if you were discriminated from your workplace or any places, the vulnerable will include those who work in the many sectors, those who use drugs, migrants, prisoners, multinationals. What you can feel concerned? First, if you were discriminated, if you would like to get help, you can reach to ปกป้อง at any time from your smartphone or tablets or computer. สวัสดีปกป้อง just write สวัสดีปกป้อง and in the search engine, you will find a system that is ready to help you. Scan here. You can put your information, your name, your ID, your phone number, gender, nationality, Thai, Lao, Vietnam, Myanmar, and what's your trouble? What's your problem? How were you discriminated? And then you will get a code. Then we can help protect you. Your problem will be noted in the system and we will work for you systematically. Starting from screening, informing the staff and the specialists in this area in doing the investigation. Our staff will reach you to get more information and find the resolution to help you. We also use this information to make change and policy change at national level. We would like to protect your rights, and we will connect with many other organizations that have responsibility in involving with this. If you were discriminated towards your gender, your HIV status, we help you at any time.
Okay, thank you. Thank you. I think at the time, we still have one more question, basically from Dr. Bruce. So he was asking about how issues are handled beyond the response to the complaint itself to prevent future problems.
So my question is, so for example, if I have a complaint, then the system is set up to address my crisis. But let's say it's a problem that I had that could also affect other people. Is there a way that then there are some steps taken to prevent that same problem from happening to somebody else?
Actually, we have a system from local level at the provincial level. If there is a case that things that happen and there are more than one, the intervention will start from the provincial level with all the people who are involved in that issues. And then if that problem is unsolved and it affects in a broader population across the national level, it will reach to the department at the center in Bangkok. It's automatically working like this.
I see. Thank you very much. That helps explain. Thank you.
All right. So with that last question, I think we're going to close with the presentation from Thailand. The thing why we are so interested with the crisis response center, I think beside the community-led monitoring, the crisis response system or the feedback system is also another quite an interesting point that we can do in regards to the stigma discrimination reduction programs. So for the next session, we will going to hear about the presentation from the Philippines. The one who's going to present it for the country presentation is Dr. Angelo Juan Ramos, MD, MPH. He's the Executive Director from the Sustainable Health Initiative of the Philippines Corporations. Without further ado, Dr. Angelo Juan Ramos, please go ahead.
Right, so good day, everyone. So I hope you can hear me and also that you can see my slides.
Make it bigger, yeah.
Okay,
cool.
Thank you very much. So this is our report on what we have been doing on our stigma and discrimination reduction activities here in the country. But before I proceed, I'd just like to maybe extend my thanks to our team at SHIP for really setting up this and preparing these slides, not with Dr. Kate Laritana and also our SHIP team led by Ivy and then Stephen and Matthew. I'd also like to thank Dr. Janice Kawili of PESMID for also sharing her inputs here, as well as Dr. Louis Ocampo of UNAIDS Philippines. And of course, thank you to the team at HEALTHQUAL. So obviously, just like in other countries, COVID-19 has had a lot of impact on the implementation of our projects here. We officially started the Philippines network back in October 2020. But this has been very challenging in the sense that, we haven't done any site visits for mentoring and coaching. So a lot of this has become virtual. So even our virtual meetings with the different hospitals have been reduced because many of them have been busy with COVID-related initiatives. So it also led to a reduction in our data collection and reporting periods. So far, we just have one round of our baseline surveys, and our intervention period has been reduced to one. So it's currently ongoing. So because of this, obviously our hospitals, have also a lot of challenges related to COVID-19. So many of our healthcare workers in the partner hospitals, including our infectious disease doctors, are really busy with COVID-19 activities. There's been a lot of staff and organizational realignment towards the COVID-19 response. There's been limited face-to-face patient consultations with the HIV treatment hubs. But there's also an opportunity, and there's also a lot of things that hospitals are doing in terms of coming up with innovative solutions. So they've been doing a lot of telemedicine and also courier delivery of ARVs during these times. So I'd like to share with you the results of our baseline stigma and discrimination surveys. So this has been done mostly online, and this is an example of a picture in one of our partner hospitals. So they have these posters wherein patients and even healthcare workers can just use a QR code to answer the surveys. So for our patient surveys, so we have been using the same questions that the Southeast Asian Network has been using. And the patient surveys have been carried out between January of March of this year. So our general instructions to hospitals is that they do convenience sampling and maybe involve at least 10% of their patients in their hubs. So these surveys have been designed and are carried out using REDCap, the REDCap software. So I'd like to thank Dr. Kren and his team at the University of Chiang Mai really for helping us out here. And then, of course, we have alternatives depending on, internet or power situations in our partner hospitals. So there are backups like Google Forms or even paper-based surveys. And these surveys are done as an exit survey. So once the client has finished his or her appointment at the clinic, they can answer the survey there, or they can just go home and answer the survey at their own convenience. So, we've had 12 tertiary hospitals around the country, both private and public, participating in this. So for this baseline period, we've had around 909 clients who have responded to the survey. So it ranged from one hospital at 2 respondents, and then to a maximum of around 228. So there's an average of 76 responses. So the majority, 91% of the respondents are male. Okay, as to age, so majority are between 24, 34, and then 35 to 49 years old. And many of the respondents say that they have been diagnosed for at least 4 years or more, right? So the key populations who participated, so again, most of them are identified themselves as MSMs. So there's some respondents, a few respondents who identify as transgender, and also a small population that admit to using drugs. So as to the responses and the results of the client's experience questions, so you can see across many of these questions for patients, there's generally a good client experience across the 12 participating hospitals. In terms of clear explanation and provision of health information, where they afforded privacy and confidentiality, the involvement of the patient in their care and treatment, is the clinic welcoming and friendly, being treated with respect, and as well as their perception that the health provider gave them enough time, during their visit. So there's very small proportion of respondents that say that they did experienced some form of discrimination from a healthcare provider or other staff member. So again, quickly, the demographics of these responses. So again, I mentioned already this, that male, their age range, and all of them are PL-HIVs, and majority are MSMs. So of those small proportion of, I would say, negative comments from the clients about stigma and discrimination experiences in their hospitals. So if you group these comments, many of them would say that there were some issues that they've had with personnel. So there were some examples, for example, that they had stemming discrimination with, for example, the security personnel or the reception, some form of discrimination. There's also some issues that were raised about the facilities. So they weren't set up. Some facilities weren't set up in such a way that, according to the clients, they did not feel safe, or there wasn't any privacy in terms of their presence there. And of course, some were also saying that they were simply not given enough information by the healthcare workers. So these were the usual complaints that the survey picked up, right? So the other set of surveys were on the healthcare workers and staff. The baseline survey was also conducted during the same time period, early this year. And we instructed the partner hospitals to administer the survey to all of the health workers and support staff working at the HIV treatment hub, as well as staff from other departments in the hospital that they think would have contact with the PL-HIVs. So for example, the laboratory, radiology department, IM, OBGYN, ophthalmology, etc. So we also used RedCap as the platform for the online surveys, with alternatives being Google Form and paper-based surveys, right? So out of the 12 hospitals, we've had a total of 915 healthcare workers and staff who responded to the baseline survey. So there was actually one hospital that did not submit any accomplished surveys, and then on the other end, we have around 319 respondents from one hospital, so an average of 76 respondents. And this time, from all of these health facilities, almost 70% of the respondents were female, right? And then most of them said that they've been working in the facility from between 1 and 5 years. So these are the maybe the relevant and interesting survey results that we got. So as of the baseline results, so around 6% of the respondents say that they've observed some of their fellow healthcare workers that were unwilling to take care of someone who has HIV. There were around 20%, 19% who said that they actually avoided physical contact when providing care. But again, maybe we need to also consider that this was answered during the COVID pandemic. There's also around 6% that said that they've observed fellow healthcare workers providing poorer quality of care. And there's also maybe around 25%, maybe a quarter of responding saying that they either do not know, they are unaware, or they know that there are no written policies in their facility regarding the protection of PL-HIVs from discrimination, or any policies that prevent HIV transmission among healthcare workers, right? So other relevant findings from the baseline surveys. So in terms of, the statement, women living with HIV should be allowed to have babies. So in general, there's, a big proportion who agree with this statement, but there's still some respondents who either disagree or strongly disagree with this statement. The next one is about healthcare workers getting worried about getting HIV if they draw blood from someone who has HIV or suspected to have HIV. So it's still significant here that there are health workers who are still very worried about that happening. And there's also a small proportion of respondents saying that they do not agree that their facility has adequate supplies that can help reduce the risk of them, the health workers, getting infected, right? So what we did in sharing these results with our partner hospitals was we had sometime in May of this year, we shared the aggregate data. So these are all the data I showed you is really aggregate data of all the hospitals. But we wanted to observe confidentiality of the individual hospital data. So after we did this presentation, we sent the individual hospital data sets to each facility so that they can start, working on the data sets and see how they can respond to that. So just quick, I'd like to share maybe what we realized were the limitations of the survey tools that we used for the baseline. So we were unable to collect data, for example, on, we weren't able to differentiate in the healthcare workers and whether they were in the HIV clinic or they were non-HIV providers. So we weren't able also to, to get any data on the service areas where they were working in the facility, as well as what kind of provider they are, and are they a doctor, nurse, etc. So what we're planning to do is to add these to the questionnaires when we do our second round sometime in October. And I think one important limitation here is that because on the side of the patient surveys, right? So we just got the ones who only answered the surveys were patients who were also actually coming into the facilities. So those who were lost to follow up, we weren't able to get any data from them, and this might be significant because they would have they might have very valuable data to share in terms of why they are not in the facilities anymore. So we are continuing our implementation and interventions here in terms of our QI programs. So we've had 5 national network meetings since November of 2020. And as I've mentioned, we've done the baseline surveys early this year. So from now until the end of September, we're asking our hospitals to implement their interventions or their innovations based on the results of their baseline surveys. And we do constant communication with our site coordinators for hospitals through emails. We have scheduled Zoom meetings, and we have a very active Viber group. So so far, after the baseline survey, 11 hospitals have submitted to us their plans or their ongoing initiatives for SND reduction activities for patients and or their healthcare workers. Again, based on the results of the first round of the survey. And of these hospitals, 8 of them are already working with their existing QA or QI teams or departments in their respective hospitals. So there are around some hospitals that don't have these QI teams, or we are working with them individually to assist them. So the schedule of the next survey round would be this October, right? I'd just like to share with you an example of maybe one of our partner hospitals doing something from what they got from their baseline survey. So this is Bahay Lingad. So this is a hospital-based HIV treatment hub in Central Luzon in Angeles City. So this is a couple of hours north of Manila. So this facility services around 1,000 plus patients who are on ART, and then they have this complement of clinical staff. They have a nurse, a nursing attendant, two case managers, and 2 doctors, as well as 4 administrative staff and 3 staff who have been seconded to do prevention work. So this is out of a total contingent of more than 1,000 staff across the entire hospital. So based on the results that they got from their hospital, specifically from what they got in terms of the healthcare worker results, healthcare worker survey results, and the patient results, what they did were the following. So they instituted a new HIV policy implementation in the workplace, a statement. So they did this because they want to prevent further discrimination among patients and employees. So this implementation, this policy has been cascaded to the other departments in their hospital, and they want to make sure that the employees of the hospitals would comply with these policies. And they have, based on the comments of the patients and clients from the baseline surveys, they realized that they needed to improve the setup of the treatment hub itself in terms of providing more privacy and confidentiality. So as you can see from this picture on the right, they've installed these cubicles so that there's more privacy during case management. And it's good that at this stage, this facility has become a partner of the EPIC Philippines project. So they were able to get funds to do these necessary structural improvements. So they also started to implement, survey forms in their facilities. So they ask patients now to answer. So they have their own survey forms. So their survey forms are really used for feedback. And what's good is that they discuss these feedbacks during monthly meetings of their HIV teams, so that they would see how these responses and feedbacks will better the quality of service they provide to their patients, right? So on to the national management strategy in the country. So recently, we've had the Philippine National AIDS Council. So this is a multi-stakeholder national council that is under the Department of Health. So they have crafted this human rights roadmap. So obviously there's stigma and discrimination is really a very big component here. And this roadmap is now being used as the overall vision of the country. And this has been used to come up with strategies and how to operationalize these strategies in terms of addressing stigma and discrimination. So because of this, the country is now joining the global partnership to eliminate SND, and we're striving to work on eliminating SND in these different areas, community, workplace, education, healthcare, justice, and emergency. And at the same time, we are the Department of Health and other stakeholders are planning to craft the next AIDS medium-term plan. So this is the national, I would say, strategic plan for the country for the next 5 years on how to tackle the HIV and AIDS crisis in the country. And so we also have the stigma index in the Philippines, which was done, I think, sometime around 2018. So the results of this stigma index were really important in putting in a lot of inputs towards the crafting of the human rights roadmap, as well as I would hope that it would also feed into the crafting of the AIDS medium-term plan for the coming years. Other national programs that are being done now. So as I mentioned, there's the human rights roadmap, and or there's already a lot of plans and initiatives to scale stigma and discrimination QA activities. So for example, WHO Philippines is developing a training manual on SND for healthcare facilities. So there's also an M&E toolkit. So this is being drafted by WHO, UNDP, and some other multilateral partners. So this is a toolkit really that will be used to monitor and evaluate the different HIV treatment facilities. So there's some stigma and discrimination indicators in this toolkit. And I hope that maybe with the next iterations we can see how we can expand the stigma and discrimination part there. So there's also work that we're doing with the Australian Federation of AIDS organizations under the SCIPA initiatives. So we are scaling up the SNDQ activities also now with the primary healthcare facilities that are being run by community-based organizations and some other local government HIV treatment facilities. Of course, there's also partnerships with the FHI 360 and the EPIC program. I know that they are integrating stigma and discrimination QI across all of their programs here in the country. So at the subnational level, so I mentioned our work with EFAO and SCIPA. So we have invited some regional offices of the Department of Health, particularly regions 3 and region 9, to participate in our SNDQA initiative. And we've already also invited other regional and program offices of DOH to take part in online workshops and events. For example, like this one. So hopefully some of them are here. So we're doing QI coaching work now. So we've shipped our organization. We've gotten a QI consultant to help 4 hospitals in our network. So this consultant will provide coaching, mentoring, and monitoring assistance to these hospitals. But the challenge is, of course, because of first the limited time. Because by the end of September, we need to wrap up this first round of initiatives before we do our second round of surveys. So it's a challenge. What quick initiatives can be done and QI measures can be done from now until the end of September. And also, of course, there's the challenge of having to travel or to do just virtual coaching with these hospitals. So so far our QI coach is really doing using this approach, this metric, the assess assist approach in assisting these hospitals with their QI interventions. So as you can see, it's a very comprehensive methodology in guiding the hospitals from designing their intervention, doing some mentoring, preparing them for mentoring and coaching, actual implementation, and also looking at the short, midterm, and long-term outcomes of their initiatives using a QI lens. And for the QI QI method, the QI coach would work with these 4 hospitals and using the PDSA template. So they'll be using these templates when they do their QI work until September. So quickly, as of next steps, we are planning to do, the network is planning to do here. As I mentioned, we have our QI consultants, our QI consultant now, who is working with the 4 hospitals. We are, SHIP is going to scale up our SNDQA initiatives, and then we are including community-based HIV primary care facilities. And we will be working with WHO Philippines and some partners to develop that SND training module for health workers. And of course, our partner, the Philippine Society for Microbiology and Infectious Diseases, or PRISMID, is going to strengthen its capacity, the capacity of its member physicians for QI work. So they will become subject matter experts as well as mentors to hospitals. And I hope that this can also be scaled up to more hospitals in the country as PSMID will also start tapping QI coaches. So all of these next steps, all of these activities will lead to maybe strengthening our network to really work more towards policy influence and formulation. So maybe we can achieve the level of really national initiatives that our neighbors in the region like Thailand, like Vietnam, Cambodia, and the rest are doing. So with that, maraming salamat. Thank you very much. And we're here to answer your questions. Have a nice day, everyone.
Okay, Dr. Ramos, thank you so much for the great presentation. So in summary, it's basically, despite Philippines just recently joined the QI network, but then we also, at the same time after that, COVID situation is happening, and then they managed to conduct a survey using an online and with the help from the Chiang Mai, and then by using the QR code and with the 12 participants from the 12 hospitals in the countries, and they also have the policy and workplace and survey form as well, feedback form in the piloting clinics for the survey, and they managed to produce a roadmap by synergizing any country effort, and also planning to joining the Global Partnership Initiative, which is very, very good, because I'm the country community focal point for the global for the regional Global Partnership Initiative, and I'm looking forward for that. And then to try to interlink with the stigma discrimination, and also there's a great logical framework that you guys develop. I think is very, very, very good. And Bruce was asking, is it possible to share it, that framework, so other can using it? So I have one question, basically, coming from Hyvin, which is the what is the intervention that the team did to eliminate stigma in the community, like directly to the community? So maybe you can answer that one first.
Well, to be honest, since we're working with the hospitals for now, we haven't really tackled stigma to community levels. So we'd like to, yeah, I think that's something that we'd like to look at when we do our work with community-based organizations. So I guess this is going to be an easier, well, I wouldn't say easier, but there will be a better contact with the community and to see what the stigma issues are in that regard. Thank you.
And then another one question is like, do all the participating hospitals have a previous training on the QI? I know, I think you already mentioned, but we can explain a little bit more on that.
So far, from my experience working with these 12 hospitals, it's really different levels. So I guess some of the bigger hospitals would have their own QI or QA departments. But maybe if you talk to the HIV hub teams themselves, or the HIV facilities themselves, many of them, for example, surprisingly, do not have any prior contacts with their QA or QI departments. So I guess in terms of the hospitals, this is where, for example, the commitment of PISMID will come in, that they can also help out these different hospitals in strengthening their QI efforts.
Okay, so now I have my personal question, basically. So you mentioned about the stigma index, you know, the one that conducted in 2018, stigma index 2.0, and I also heard the Philippines also planning to roll out another stigma index, but this is kind of this time is different. Maybe you can elaborate more about this new stigma index is all about. Thanks, Dr. Ramos.
Right, thank you. For this, I'd like to invite, I think, Dr. Louis Ocampo from the AIDS Philippines maybe can help us answer this. Doc Louis, is it okay? Are you here?
Yeah, I'm here. Thanks, Dr. Cello, and thanks, Harry, for that question. You're right. We had the stigma index study sometime in 2018, early 2019. And obviously, same with other countries, that tool needs a lot of improvement because of some limitations. Now, for the country, we are actually envisioning to have our own study, and then including other KPs identified in the country, like MSM, transgender women, because the current tool used by GNP Plus does not include the other key populations. So, and since we, as mentioned by Dr. Agello, the country is now engaged in the global partnership to eliminate HIV-related stigma and discrimination. And I think this baseline would be a good starting point for us to identify, you know, what are the experiences of our key population, including MSM and other transgender women and people who inject drugs. So that's the plan for the country in terms of the stigma and discrimination study. Thanks.
Thank you, Dr. Louis. I think this is very, very great. I mean, I'm you know, when I heard that, I'm very happy, a little bit goosebumps, because you know, when we countries start to decide to join the global partnership, I think they have to have a rich baseline to start to work moving forward. I think it's a very, very great start. So there's another question probably from Todd Palak. Do you mean that you are recruiting HIV negative key population? This is related to the previous question, I think the participating hospital have previous training on the QI.
Yeah, okay, so thank you for the question, Todd. For the hospital, no, for this SNDQI project with hospitals, we really focused on PLHIVs. But when we are our plans are, as we are expanding to CBOs and primary care facilities, we are also going to include clients who go the key populations and then HIV negative clients as our respondents in the surveys, to also see, to also document any stigma and discrimination issues for those key populations.
Okay.
Thanks. If I could I add one? Actually, my question was related to the stigma index.
Okay.
Sorry for that. Didn't put enough information in the chat, because we just did the stigma index. We helped support in Vietnam, the Vietnam Network People HIV. And we're about to finalize the report, but we found that it was lacking because we have a lot of intersectional stigma, and the tool attempts to measure that, which is great, but in terms of HIV prevention, there's a lot of stigma and discrimination against key populations, and that may prevent them from coming forward for PrEP services, for example. And the tool didn't allow us to measure that kind of stigma in people who may be at risk for HIV but are not infected. So I wasn't sure whether the previous speaker was talking about the Philippines revised stigma index, whether he meant that they would be including HIV negative KP in the survey, or he was talking about PLHIV who are from key populations.
Yeah, let me answer that, Dr. Cello and Harry. I think what we are planning for the country is to come up with our own tool to measure even prevention. And as you said, there are intersectional form of stigma and discrimination, and the current stigma index tool only captures the experience coming from PLHIVs. For the country, we want to include other KPs who are negative, so that we can capture all spectrum of stigma and discrimination beyond PLHIV. So that's the plan. Over.
Thank you, Louis. So I think as a history back from when we talk stigma index was basically initiated by three global PHIV organization, three global organizations, which is GIP plus, ICWU, and UNAIDS. The idea is to make sure the stigma discrimination among PLHIV, that's what's happening in the early 20s, and then by the time coming, I think they try to revise all the tools and the monitoring of the stigma discrimination guidance, and then they change it to, that's why they have the stigma discrimination to stigma index 2.0 that some countries has been carrying out right now. Okay, so before the next session, I think we will have a break for 50 minutes. But before that, please switch on your camera, because we will take some pictures before we go into the break. Anyone already open their camera? Charlie, let me know if you already capturing everyone.
Yep, I'm just going panel to panel. Okay, I got it. Thank you.
Nice beard, Louis.
All right, so we will have a 15-minute breaks and come back again around 10:25. Yes, is it correct, Bruce?
Yep.
All right.
10:25 Bangkok time. Yes.
Right, and then we'll do an introduction to the breakout. We'll have a talk from Thailand about self-stigma curriculum, and then we'll do an introduction to the breakout groups, and then we'll have the breakout and report back at the second part of the meeting. So.
Yep.
Okay, thanks. So we'll be back at what you said, 25 after the hour. Is that what you said, Charlie?
Yep.
Okay, so 25 after the hour, whatever hour that may be, wherever you are. Thank you. So it's 25 after. If you are back, can I ask you to just briefly turn on your screens so we know you're there? So otherwise, it's a little hard to tell if folks are actually back. Thank you, Angelo, Dr. Anita, Chad, Samsia, Ivy. I will stop saying names, but I think we've got a fair number of folks back. So I think we can get started. Charlie and I are going to tag team a little bit in the next part of the meeting, but I wanted to start off by introducing our next speaker. We asked the Thai team to pull out their segment of the presentation on their self-stigma curriculum and review that for us. And of course, I unfortunately lost the little slip of paper with the bio. So Charlie, if you have that handy, can I ask you to read the introduction? Apologies for that.
Sure. So at this time, we're welcoming a short video on Thailand's self-stigma program and curriculum from Dr. Sanisa Sutrakol, who is an assistant professor, faculty of nursing at Chulalongkorn University. She is a specialist of advanced practices nurses, part of psychiatric and mental health. And we also acknowledge contributions from Ms. Jaruni Sirapan from the Institute of HIV Research and Innovation and the Foundation of AIDS Rights, as well as the Division of AIDS and STIs.
Hello, everyone. Thank you for the opportunity to present our work on reducing self-stigma. Start with seeing the problems that arise in the KPL, HIV, and key population, whether they are lost follow-up, lack of medical adherence, poor self-care, stress, depression, poor work performance, and poor quality of life. We had 6 years experience with SAP project. And firstly, I need to thanks to the foundation of AIDS Right team for giving me the opportunity to work on this matter. And I will present that with 3 phases of our work. Let's see for phase 1, the SAP development. Phase 2, the implementation in healthcare facilities. Phase 3, the development of SAP version 2. And for phase 1, at the beginning, it was developed to be applied and as the therapy by training service providers and community leaders to help our population in community setting. The program development process consists of 5 steps. First step, start with a literature review to find the conceptual framework, and we select Livingston and Boyd 2010 to be our conceptual framework, and we review the factor related to self-stigma too. Second step, work with focus group on target population and care provider to confirm our review and to ensure accuracy of the data. And third step, draft program activity, and then recheck with the same focus group population again. And for the fourth step, perform validity check by group of experts. And the last one is was program tail. And let's see for the aim of the SRP, include helping individual person to deal with negative thoughts about themselves related to their status, and to regain their power to better cope with pain inside, as well as stigma and discrimination from outside to affect on their quality of life. We work to test the effectiveness from experimental study. It was found to be effective in reducing self-stigma, leading to better health behavior, changes both receiving continuous treatment and medical adherence, good at work, better family relationships, and reduce drug use behavior, or can be controlled in the case of person who has a behavioral problem with substance abuse. And let's see for the model. Focus on the model. It describes an external situation that occur to a person, which is being stigmatized by society causing, and describe that internal process that take place from the experience of encountering the stigma. Then stigma was recognized, leading to more negative for case, and we will find that our population will present guilty withdrawal, isolation from society, and maybe and from other person. So for our program, we create the activities based on cognitive behavioral therapy. The activity in the program consists of 5 modules. Module 1, making everyone know and understand the origin of stigmatization. Understand that we are the one who can cause stigma, and learn and understand self-stigma. And for module 2, learn and understand the process of self-stigma as coming from negative automatic thoughts that lead to negative emotion and behavior, and learn to check whether that automatic thought makes sense or not by finding evidence, and learn to adjust if it doesn't fit. And in this module, including learning appropriate coping and problem solving skill too. And for module 3, from self-stigma that got low self-esteem and blaming themselves. So the practice to making change by using positive thinking about themselves and their surrounding, and let them review of success experience in life to increase self-worth. And module 4, module 4, hold on for my slide, I'm sorry. Okay, for module 4, activity to find source within themselves to support problem solving to get more effective life. That is just like improve their empower. And for the module 5, setting goal for moving forward and check the plan to action. That's it. Our activity take 15 hours to complete of the program, emphasizing knowledge, understanding, self-analysis practice, and training to apply it in real life. All of that work, we work in the phase 1 is in the community setting, and move on phase 2. Phase 2, the implementation of activity in healthcare facility. We tested it in three pilot hospital, and the result were certified. But encounter obstacle in the long duration of activity and continuous follow-up. after we finish our test, the next step that we think about how to develop the program to be short and concise, suitable for usual service in healthcare facility. That while we move to the phase 3, the development of program of SAP version 2. This program still retaining the concept of original activities, include 3 sessions. Session 1 to learn and understand the thought process that lead to stigma and self-stigma and management of negative automatic thoughts, and activity 2, coping skill and problem solving under the appropriate source and support in this session. And session 3, adjusting the positive aspect in life. That's it. So for our activity, we use the time for, each activity is conduct for one hour. Total activities were 3 hours, and each activity can be performed separately. In the session, we focus on emphasizing understanding and provide example of experience to apply and for practice to use skill continuously. We mention them to strongly practice at home. And so let's see. I'm sorry, before the slide. Hold on. This one. I forgot to present about the measurement. So we measure self-stigma by using 1 question to identify how you feel about yourself at this moment. By specify a score of 0 is do not feel bad, no self-stigma, and 10 is feels so much. And the second record, clinical outcome with continuous follow-up, drug adherence, reduce drug consumption, CD4 viral load. That is the measurement. So challenge for the past work with the group activity has strengths in the diversity of experience during learning that facilitate understanding and good example for application. As now, the next challenge might be how to develop SAP again for the new normal service. Emphasis on individual activities. Therefore, it is too difficult. Problem might be for therapists to give more examples and many give many situations to help their patient learn. So that is our next challenge work. That is all our work with SAP. Thank you for your attention.
Great. So thank you, Thailand, for sharing that video and your self-stigma curriculum, which I think is very innovative to launch. I think we hear all the time about not being able to do anything about self-stigma, and so I think this is going to be really important for us to learn from as this curriculum and the embedded research program that you have with it come forward, and the results come through. I also want to point out that, as was mentioned in one of our earlier presentations about the coordination with academic institutions, and that this is a really useful strategy in general for working in stigma reduction programs. And I think there are examples in just about every country. And So I see Dr. Anita's question. We're going to move on to the breakout groups. Dr. Anita's question about sharing the curriculum. I'm not sure whether or not the curriculum is in English. Dr. Darinda, if you can let us know if it's in English, or somebody can put in the chat, and we would be happy to distribute it through the network for people. I think there'll be great interest. So Charlie, I think I'm going to turn it over to you to move us into the breakout groups. I just wanted to say that we are trying to do our best to have a distribution of people from different countries and different agencies in the breakout groups. And it's a little hard to predict all of that, but we've done our best. And if you've not gone into a breakout room in Zoom, we've pre-assigned people. So you will see that you will go into a room and then there'll be some people who've not been assigned, and then we'll assign you when we figure out who has not been assigned. Charlie has put the questions in the chat. I'm going to ask him to read them in just a moment, but also, and he'll repeat this, when you are in your group, the first thing to do is to appoint somebody as your group facilitator to keep the discussion moving, and to also appoint somebody who will report back the 3 key messages or 4 key messages from your discussion in response to the questions. And so we'll be asking each group to just share their key messages from the breakout groups. And Charlie will also go through the timing of the group. And sorry, Charlie, if I said
No
things you were
worries.
going to say, but I think all worth repeating. So go ahead.
Yes.
Yeah.
Awesome. Thank you, Bruce. So for folks who don't know me, my name is Charlie Ferrucci. I am the program manager at UCSF HEALTHQUAL. So before we begin the breakout session, I wanted to share some guidance to support you through this process. Like Bruce mentioned, each attendee has been pre-assigned to one of the 10 breakout groups. I pasted the 5 guided questions in the chat, but I'll also provide them to you on the next slide. So I ask that you please screenshot or copy the questions for reference. The breakout session will run for about 30 minutes. I will provide a 10, 5, and 1 minute warning before the session ends. The report back will run for about 15 minutes. So we ask that you please be concise and summarize key points in just 1 to 2 minutes. During the first 5 minutes, we ask that you please agree upon a facilitator and a rapporteur. The role of the facilitator is to ensure the group addresses each question, while the rapporteur will scribe notes and briefly summarize key points during the report back. So again, these are the 5 questions. I will read them and you can screenshot them while I read them. Question 1, what programs or services are available in your respective countries that address self-stigma among people living with HIV? There's a subpart to this question. Are any of these programs integrated within clinical healthcare programs and settings? Question 2, if you could design a program to address self-stigma within a healthcare setting, what would it look like? Question 3, how would this program address both HIV and reach key populations, that is sex workers, gay, bisexual, and other MSM, transgender women, and people who use drugs, who are disproportionately affected by self-stigma? Question 4, how can we ensure that these strategies to address stigma are embedded in national HIV policy and programmatic responses to reduce self-stigma in healthcare settings? So I think at this time, hopefully you've been able to either screenshot or copy the questions from the chat. Bruce, I don't know if you wanted to add any other guiding points for this.
No, I think you covered it, Charlie. If I think there's I don't know if there's a way to signal that you need assistance from Charlie in the breakout rooms, we'll rotate a little bit just to see if if there's anything that's that we can help with during the breakout. So yeah, go ahead.
Okay,
Charlie.
sounds good. So I think with that, I think we're ready to begin. Best of luck in your breakout group. I will see you all in 30 minutes. And like Bruce said, I'll be transitioning Bruce and Richard amongst all the groups to make sure that everyone's on task and doing well. So here we go.
Welcome back, everybody. Nice to see you all again. And I know there was a lot of discussion in several of the rooms. Hopefully it was interesting and productive. And we're going to spend the next part of the meeting, will probably be about 15 or 20 minutes hearing back from each of the groups. So I think we'll just go in numerical order. So let's start with group number 1. Who's going to report back from group number 1?
That would be me.
Who's me? I'm sorry.
Margaret.
Margaret Jasmine, everybody. Welcome, Margaret Jasmine. You want to introduce yourself, by the way? Part of our health team. And if your video is there, can you put your video on?
Let me get that on. Sure. All right. Hello, everybody. Margaret Jasmine from HEALTHQUAL UCSF. I work mainly with Haiti and also support Côte d'Ivoire. So it's a pleasure and an honor to be with you. Okay, so I think for my group, we had a few communication issues because not a lot of us were able to provide feedback in the beginning. So for question number 1, about the program and services available to address self-stigma. For mainly for the few team discussion, they usually use the U=U intervention, and the main issue is that that requires funding and strong commitment. So some services are available for key population and also for self-stigma reduction, but not necessarily at a national, it's not a national effort. So it mainly on a facility based initiative. Okay, number 2. For number 2, the discussion resolved about also the U=U, but also improving education for healthcare providers, so which is a very needed effort to address self-stigma. For some of our countries, but many in Haiti, there's also a need to educate patients. And also it's even the overall population, because there's a cultural issue with HIV care. So there's a lot of stigma among the entire population. Also, we think that there is a need to strengthen counseling and to educate the counselors to ensure that they have the required tools to identify and address self-stigma during those counseling sessions with the patients. For question number 3. Okay, so for that, we think that the community led initiative are very important to address that matter. So any quote.
Margaret, we can't hear you now. No. So, okay. If it, try now. No. Okay. I'm sorry. I think just in the interest of time, I'm sorry. We'll capture the comments in writing and we'll move on to group 2. I'm sorry. Who is the reporter back from group 2 to summarize the key points?
Hello, good morning.
Hi.
I am Santa. Yes, I am attending on Irene Fonasher's behalf. Presentation. So, okay. For questions 1 to 4, our country just recently approved the Human Rights Roadmap. So that will address all barriers to HIV prevention and access to treatment and care. So that is focusing on the acceptability, availability, and accessibility and quality of HIV prevention, treatment, and care. So that's for all key populations. But for self-internalized stigma, that is highly clinical. So that will engage a lot of work from our peer-to-peer counselors to be trained by our professional psychiatrists or psychologists. But then we are still working out on, in partnership, linking HIV with the community-based drug rehabilitation program. And then how would this program address both HIV in which key populations, sex workers, of those who have marginalized social identities, like people at sex work, or people in prostitution, or those who are engaged in injecting drug use. So among all these marginalized identities, we have the women who were left in the program. So we have to create a specific program for women who are in, of course, sex work and injecting drug use. And then we have the emerging women. I don't know if my community will agree, the transgender women. So we have, still we are working on the transgender women health package. Then for question number 4, we have a very good and well-sound repatriation program for OFWs, particularly addressing the needs of women and transgender women working in Middle East and some other parts of Asia or countries in Asia. So our repatriation, according to my teammate or group mate working with the migration cycle of OFWs and their vulnerabilities to HIV, and are working, and our social work attaché abroad are working so hard to address the discrimination issues of our OFWs. So that would be all. Thank you.
Great, thank you so much. And if folks have questions after the presentation, other groups, please put them in the chat. And then we'll hopefully have a few minutes afterwards. Group 3 had some technical glitches coming together, so we're going to move on to group 4. Jay, is that you that's going to report back, or somebody else?
Hi, is that me?
I don't, or did somebody else in your group agree to report back? Shara,
Okay.
is it Shara or you? I'm not sure.
No, it's actually him, Mr. Ryan. Go ahead, Sir Ryan.
Okay.
And you have help with you, so go ahead.
Yeah. So one of the things that was noticed in at least for our group is that the different self-stigma projects are not separate, meaning these are already embedded in the other different programs. So some of the things that the Philippines has done is conducting the stigma index study among PLs with HIV, and then other studies and experiences among key populations. So because of the COVID-19 pandemic, we also had to adjust to address mental health related interventions. And the Philippines is in the process of developing training modules, so those highlighting the presence of self-stigma. And then although there's no separate intervention focused on self-stigma, there is a relation to the larger mental health interventions. Same as with Malaysia. Malaysia also reports there's no specific program for self-stigma, but it is embedded in the existing modules. And it's not quite highlighted since that it's embedded into the other programs. And since that there's no actual well-structured program to address self-stigma. And then these programs in the healthcare program and settings are faced with further challenges because there are some people who do not believe in self-stigma. They end up victim blaming, and all of these add to the reflection of experiences of those PLHIVs, which becomes part of their core being. So they develop that sense of feeling less than other people because of those experiences. And so that leads to the additional difficulty of addressing self-stigma as a topic on its own, because it is not that well defined. So that is something that we're going to address. And some of the suggested programs is the programs to address self-stigma should be led by the community themselves, because they know how it feels to be PLs with HIV. And then some of the different suggestions is to integrate it as part of the client case management on an individual basis. So we need to develop a very good case management program with good counseling. And then we not just provide information, we also explore the client's concerns, the patient's concerns. And these includes addressing self-stigma and client-centered case management via individualized counseling. And because of the COVID pandemic, it adds to the stressor. So the clients have difficulties going to the treatment hubs. So some of the suggestions include getting the case managers going to doing house calls, and even online booking, online counseling, different engagements in social media for the patients to be aware of these different services. And then to reach these key populations and to integrate it into the national program, we are going to have to, some of the suggestions include peer-to-peer approach. We have support groups in the Philippines to handle these. There are learning group sessions and support group sessions to give a safe space for the patients to discuss their concerns. And although these are done individually by individual case management, seeing it in peer groups provides additional support and confidence to the PLHIVs, especially if they see influencers, celebrities who are sharing their experiences, showing that the quality of life did not suffer because of whatever they're having, whatever they're feeling, and that this will address self-stigma because they see these influencers, they see these celebrities with little to no effect to their daily living, and then they feel for themselves that yes, this can be done. This is a challenge that can be overcome. And so the different approaches are to get training case managers who can conduct group sessions to address self-stigma, and then these develop specific media materials to address self-stigma. Then we strengthen and provide capacities for mental health counseling. That's it for my group.
Well, there was a lot, and there was a lot of great stuff there. I'm not going to make any comments now. I want to hear other groups present. I'll make some very short comments, but that was a really, there was a lot there. So thank you for that very rich discussion. And then let us move on to group 5. Who's going to report out for group 5? That's
it'll be me. It's going to be me, Bruce, Harry.
Go for it, Harry. Yeah.
All right, so from the group 5, there is 3 highlighted points from the discussion based from the question that being in each breakout sessions. So basically, when we're talking about self-stigma reduction program at the healthcare facilities, mostly it's coming in the informal platform, and the initiatives come organically on each clinic, whereas the healthcare facility usually try to gather in the community at the center, and sometimes the healthcare facility is also inviting a psychologist to enhance the community self-esteem. And then from the discussion also we identify that this is still on the healthcare setting, on the small scale at the healthcare settings, but it's not really widely implemented in the nationwide. And then we had also heard quite interesting models that conducted by the community health clinic, Life Yourself. They also conducted the life coaching models, where they more embedded about these models, more embedded about the self-stigma reduction programs to empower and strengthen the community, and as well to enhance the self-esteem of the community. When we're talking about addressing self-stigma reduction programs, the discussion came up with it, well, the approach should be more culture properness should be also considered, for basically you have to be adopted into the country context, and then the programs would be also conducted widely outside the facilities and more widely implemented. And then also recommended that also to establish a community ambassador as the stigma, self-stigma reduction programs issues. And then there was another ideas that come maybe, to using the QI approach in terms of the measuring the quality of stigma also considered there. That should be to be carried out, especially for the community healthcare facilities. And lastly, since there's as the participant in my breakout session aware that this there's self-stigma is usually coming from the within of the communities, and then there's also a need to empower to strengthen the community through this using social media platform. Lastly, to make sure the strategies can be embedded in the national IT policies. We all agree that policy making should be invited, and then we also agree that data driven is very important, not only coming from the government or the healthcare facilities, but also from the community. And if it's coming from the community, in order to ensure the buy-in or the process by the data collected by the community is being used, is to involving the government, policymaker or stakeholder into one of the respondent of the praying on the study. This way, this approach is a more bottom-up approach rather than a top-up approach. That's all from group 5, Bruce. Thank
Great,
you.
Harry. That also was a lot. Thank you very much. Let's go on to group 6. Who's going to report out for group 6?
Is that our group?
That's your group, yeah.
Okay, Bettina will report. Thanks,
Yes, hello.
Bettina.
Yes, thank you, Dr. Yeah, hello, yes. So good morning, good evening to everyone. For our group, we actually were joined in by 3 countries, the Philippines, Thailand, and Cambodia. So for question number 1, what programs or services are available to address self-stigma? Actually, for Thailand, I think they've shared already. They do have the self-stigma, self-reduction program already. So they do have a pilot implementation phase going in for that, where they reach out to different ARV clinics or different hospitals and select prioritized key populations or PLHIV according to CD4 level, viral load level, and evaluate self-stigma across these populations. And based on the self-stigma assessment, they do bring in specialized training sessions or specialized sessions for these clients and improve the self-stigma status across these population. And then they do re-evaluation based on clinical outcomes and other holistic care or other evaluation scoring as well for self-stigma. For the Philippines and Cambodia, currently we don't have really any standard programs or standardized processes, but majority of self-stigma initiative, as mentioned by the other groups as well covering the Philippines, is that we do have embedded questions or embedded initiatives within our counseling mechanisms or different activities in the clinics or different activities going on in the different programs or NGOs or community-based organizations. So as applicable to Philippines and Cambodia, if we could design a program to address self-stigma, I think one of the things we started with was to have a baseline study first or baseline assessment first of what is actually needed or what is actually should be within that self-stigma program, and then develop standardized messages or standardized modules that can help or can be used by the different providers, different groups, and different community groups on moving forward a self-stigma program. And for number 3 is how do we think this program can address both HIV and key population? How can this be improving the different access to services? So based on the group, we think that having a self-stigma program will actually increase or improve the access of HIV services or different KP services as well, because as we know, self-stigma is the beginning barrier to actually engaging or addressing the problems across the different KPs in terms of accessing care across the continuum. And for number 4, how we can ensure that these strategies or these activities that address stigma are embedded in the national HIV policy. So for Thailand, I think the current program they have for self-stigma program is it's on a pilot scale, but they've involved many collaborators already. So once they see that this will be effective, they will actually embed it in a national policy level. So it's good to actually start to involve, even at the pilot phase, to start to involve different collaborators as well as with the Ministry of Health or Departments of Health already, so that we can start already building in that concept of having a self-stigma program. And for the Philippines, I think it was mentioned by the previous group already, there has been a human rights roadmap already integrated or was developed, and it should be integrated in the AIDS medium-term plan for the country by next year. So that will be a good opportunity to also include a self-stigma program within that roadmap. And for Cambodia, they also have a national SOP already for stigma. So that was released in July 2021. So they think this is also a good opportunity or a good open ground for them to start also introducing programs on self-stigma. So that's all from our group. Thank you.
That's great. Thank you. Thank you very much. And it was good to hear about the different countries that came out, the different issues that came up from the different countries. Okay, we have just left breakout 7 and 8. Charlie, I know we merged 10, and then we don't have 9 either, right? So we have 2 more report outs. Who's going to report out for breakout 7? That was the group that had Arvin, the Cambodia ministry, Kunpachara, and Tung from Vietnam. Who was supposed to report out? Is there anybody still here? Tung and Arvin, I see you're here. Kunpachara and the Cambodia folks are here. Who's supposed to report out, or are you not going to be reporting out?
Hi everyone. The group 7 we have a EV reporter, but actually we don't know what happened if we left the group breakdown. So we have no discussion more on that.
Okay.
So I think we have no report on this yet.
Okay. Okay. All right. Thank you. And we do have a report from 9. So we have 8 and 9. Who's going to report out from breakout group 8? That's the one Angelo and Fung are in. Okay, great. So if I can ask you to focus on some of the things that have not yet been said, that would be great. Yeah, thanks. Go ahead.
So thank you very much. So I guess much has already been said, but maybe just a few additions because in our group we have Philippines, Vietnam, and Myanmar. So for the first question, so basically for the Philippines, that's already been answered here. Insofar as Myanmar and Vietnam, so the people in our group said that they're not aware of any self-stigma programs in these 2 countries. So for number 2, basically a wish list for a self-stigma program. So we're looking at maybe developing a program that looks into 3 domains, maybe on training, on the training side, and then on the platform. So for platform, for example, can be a mobile app because it will be an easier way for clients to reach clients and then answer any questions about self-stigma. And then training, and then maybe intensive intervention for following up. And then also there needs to be an assessment component to this. So the assessment needs to adapt. We need to adapt models and trainings that have been done in other countries, and also involve, in the assessment, KP-led organizations and healthcare workers. For the third question, I guess it really necessitates close involvement of the KP groups, and then also community-led initiatives will also need to be really taken into consideration so that access to this program would be much quicker. And then lastly, for number 4, how do you ensure the strategies, when it comes to influencing policy and programmatic responses? So we're looking at maybe generating evidence. So there can be research on this. There can also be policy papers that can be developed, as well as maybe sharing sessions like similar to this, where we can talk about and share success stories of change, and best practices. Well, yeah, okay, that's basically from our group. Thank you.
Whoops, yeah, great. Thanks, Angelo. Thank you for summarizing that. I think then last but not least, we do have I9, if I'm saying that correctly, from group 9.
Hi, this is AE from Myanmar.
AE, I apologize.
No worries. So we are a group of 2 people, one from Malaysia and one from Myanmar. It's me. Therefore, if our thoughts reflecting our country would not be incomplete, and so suggested to combine with the responses from our country team who are participated here. I think most of the responses are already covered. Let me highlight specific points for each question. So specifically for the question number 1 for Myanmar, Myanmar has been implementing the community feedback mechanism addressing health, human rights, and gender stigma issues. So we haven't developed any specific program for the stigma among the PL-HIV yet, but we would plan to expand the use of this CFM tool in integration with other globally recommended tools for the CLM to include self-stigma among PL-HIV. So for the question number 2, so we thought that the same as the inputs from all relevant stakeholders are very critical. And we also share that the need to have adequate resources from the funders, international funders, as well as funding committed by the country for the nationwide self-stigma program to be operationalized and as a sustainable one. And also, we also think that the need for the capacity building for how to develop self-stigma program and contribution from the PA-HIV, also the program for the expansion of the healthcare worker sensitization training to raise their awareness. And also we need the advocacy and the participation from the KB community and the, thank you. And for the question number 5, I think so. And for specifically for Myanmar, we have developed the 5-year national strategic plan, and we still need to get buy-in from our key stakeholder and the government to develop that stigma program. And so also maybe we need to discuss how to develop roadmap by embedding key indicator for the stigma program. So this is all from our group 9, and over to you.
Great, thank you so much, AE. And so that was great. There was a lot that came out of there, and I have to say that when we set this up, I wasn't sure how much information we were going to get. I think sometimes people are a little stuck with stigma, but really there's a lot of thinking going on. And then of course we saw the wonderful example from Thailand. So I think some of the themes that came out are we're focusing on U=U as a key strategy and promotion in health facilities, that addressing self-stigma can be done by embedding it in other programs, as well as also addressing it separately, and particularly with connections to mental health and to case management programs. I think the importance of capacity building, which was presented several times and also just now, underscoring the importance of addressing all different levels of the system, for the community, for healthcare providers, and making sure that things get embedded in national programs and training programs. And of course, the importance of peer programs, the challenges of making sure that self-stigma is broad enough, addressing the programs that address self-stigma are broad enough to embrace all key populations. And then last but not least of the things that I was able to take away from the report backs is that, of course, QI can also be thought of as a strategy to address issues that emanate from stigma that can then translate into helping reduce self-stigma at the same time through their interventions of making things friendlier and less stigmatizing to people. So that's a quick summary. Of course, we'll have notes written up in summer and a capsule version of these different ideas. There were a number of things that came up in terms of documents and curricula, and we will include those in the Dropbox for sharing. So that's all I have for the summary. In closing, I want to thank all of you for your input, and all of you in particular who stayed through the whole 4 hours of the meeting. This was a really stimulating meeting, I thought, in terms of the presentations and the participation. And I'm also quite excited about the next meeting, and I'm going to ask Charlie to quickly put up the agenda. That should take about a minute, and then we'll give you 5 minutes back. So I'm particularly, we will have the regular presentations from Lao PDR and from Malaysia, and hear about the progress that's being made there. And then I'm excited that we'll have Dr. Alex Carulian joining us from the Fenway Institute in Boston, who has done a lot of work in the area of mental health, including addressing stigma. And so it's a really great follow-on to the issues that were just brought up in the discussion. So I hope you'll all be able to join us and look forward to that. If there are any questions or comments before we close, we can take them. And if not, then we'll sign off and wish you all a pleasant day and a lovely weekend. And we'll say goodnight to those of us over here on the other side of the ocean.
Thank you.
Bye-bye. Thanks, everyone.
Bye. Thank you.
Take care.
Bye-bye. Thank you, everyone.